right now, while you are sitting in that chair, something is happening inside your lower back that nobody has properly explained to you. A slow, silent process, one that your doctor saw on the MRI, named correctly, and then stopped investigating entirely. You have probably been given the diagnosis: disc degeneration, facet arthropathy, spinal stenosis. Maybe your doctor pointed to a scan, traced a finger along the image, and said words that stay with you. This is degenerative. This is what the body does at your age. Management, not cure. And maybe you accepted that. Because why would a doctor lie to you? Here is what nobody told you. That degeneration on the MRI, it is real. It exists. But in the majority of chronic back pain cases in seniors over 60, it is not the primary driver of your daily pain. The real driver is sitting right now in your blood, completely undetected, because the test your doctor ordered is measuring the wrong thing entirely. I am going to give you 30 minutes that might change how you understand your back pain for the rest of your life. Stay with me, because what I am about to share has canceled surgical consultations for patients who believed they had no options left. Now, have you ever had a doctor specifically test your magnesium levels the right way? Type yes or no in the comments right now. I will explain what the right way actually means. And I think most of you are going to have the same answer. Now, Sandra is 67 years old. She lives in Virginia. She spent 31 years as a postal carrier, walking routes, lifting parcels, 6 days a week in every weather condition you can imagine. She is one of the most physically capable people I have ever treated. She represents a pattern I have seen dozens of times. When she first came to see me, she had been in daily lower back pain for 4 years. She had been through physical therapy twice, steroid injections, 3 different pain specialists across 2 states. Her most recent physician had called her condition chronic and irreversible degenerative disc disease and suggested spinal fusion as the next step. Sandra sat across from me and said something quietly. She said, "I used to carry mail through blizzards. Now I cannot carry groceries from the car to the kitchen." Hold on to that. Coming back to Sandra shortly, because what I found when I looked at her records changed everything. My name is Dr. Michael Kent. I have spent over 20 years in medicine, focused entirely on senior health. And the truth I am about to share, it is not new science. The research has existed for decades, but it lives in journals that most physicians do not have time to read. In a healthcare system that gives doctors 7 minutes per patient visit, 7 minutes to hear your history, do an examination, order tests, and file the referral. 7 minutes for 4 years of your pain. So I am going to take the time the system would not give you, because you deserve to understand what is actually happening inside your body. Everything I share today is grounded in published research. But please, work with your own physician before making any changes. This is education, not a replacement for medical care. And if you are watching this channel for the first time, subscribe and tap the bell icon now. I put out new senior health content every single week. Information that falls through the cracks of a system that does not have enough time for you. Do not miss what is coming. Now, let me start with the fundamental question. What exactly is magnesium doing in your back muscles? And why does its absence produce the specific kind of pain that most seniors are living with right now? Magnesium is the 4th most abundant mineral in the human body. It participates in over 300 enzymatic reactions, energy production, DNA synthesis, protein formation. But for understanding back pain specifically, 3 mechanisms matter most. And I want to walk you through each one carefully, because once you understand these, you will never look at back pain the same way again. Here is what most doctors do not have time to explain in a 7-minute visit. Your deep spinal muscles, the ones that wrap around and support each vertebra in your lumbar spine. They work harder than almost any other muscles in your body. They contract and release constantly. Every shift of your weight, every step you take, every breath you draw engages them in some small way. For that process to work correctly, those muscles require two minerals in precise balance. Calcium triggers the contraction. The squeeze, magnesium triggers the release, the letting go. Now picture this. Picture your hand gripping a rope tightly. That is calcium doing exactly its job. Now imagine the signal telling your hand to release never fully arrives. The hand stays partially gripped, not a full cramp, not a complete spasm, just a sustained partial tension that does not release. Hold that grip for 1 hour, 2 hours, all day, every day for 4 years. That is precisely what magnesium deficiency does to your spinal muscles. It impairs the relaxation phase. The muscles contract normally enough, but they cannot fully let go. They stay in a state of chronic low-level tension, and that sustained tension produces a specific kind of pain, deep and relentless and constant, that most seniors are told is their arthritis or their disc degeneration or their age. But here is what makes this even more important. And this is the part that explains the sudden severe spasms. A muscle that is already chronically partially contracted is already operating close to its fatigue limit. It has almost no reserve. So when you make even a minor movement, bend slightly wrong, reach for something on a shelf, roll over in bed, that muscle has nowhere to go. It tips over into full protective spasm with almost no provocation. You call it throwing out your back. What actually happened is that a muscle running on almost no magnesium finally hit its limit. Think about that for a moment. The spasm was not random bad luck. It was predictable and preventable. Now, that is mechanism number one. But the story goes considerably deeper. Stay with me here, because this next part is the one that most physicians never explain. And it is the key to understanding why some seniors have pain that seems completely out of proportion to what the MRI actually shows. Your nervous system has a built-in volume control for pain. A specific receptor on your nerve cells, called the NMDA receptor, regulates how strongly pain signals are transmitted upward through the spine. And magnesium physically sits inside that receptor like a cork in a bottle. It blocks excessive activation. When magnesium is present in adequate amounts, the cork stays in. Pain signals are proportional to actual tissue damage. A small irritation produces a small signal. A moderate injury produces a moderate signal, but when magnesium is deficient, the cork comes out. Those receptors open fully and your nerves become hypersensitized. They start amplifying signals that should be minor. Movements that should be painless become painful. A gentle stretch in the morning generates sharp sensations. Rolling over in bed wakes you at 2 in the morning. Sitting in one position for 20 minutes becomes something you dread. Researchers call this central sensitization. And it is one of the primary explanations for why some seniors experience pain that seems wildly disproportionate to what imaging actually shows. The disc degeneration is real. The facet changes are real. But the pain, intensity, the daily crushing weight of it is being amplified by a nervous system that has lost its natural volume control. And magnesium is the volume control. Now, I want to use a comparison that might make this click. Think about a car alarm system that is properly calibrated. It sounds when someone actually breaks into the vehicle. It responds to real threats. But imagine that alarm system becomes miscalibrated. Now it goes off when a truck drives past, when the wind picks up, when a neighbor opens their car door 3 houses down. The alarm is working, but it is responding to the wrong signals, with the wrong intensity. That is what magnesium deficiency does to the nerves of your back. It miscalibrates the alarm. Signals that should barely register get broadcast as emergencies. And you spend your days in pain that your MRI, that your orthopedic surgeon cannot fully account for. But here is what gets almost no attention at all, the third mechanism. And this is the one that ties everything together. Your body produces a chemical called substance P. It is a neuropeptide, a signaling molecule that does two things simultaneously. It amplifies pain signals and it drives inflammation in surrounding tissue. In an acute injury, a substance P is protective. It mobilizes healing resources. It creates awareness that something needs urgent attention. It is supposed to be temporary. But when magnesium is chronically deficient, substance P production does not switch off properly. It keeps running at elevated levels, creating a persistent low-grade inflammatory environment around your spinal discs, your facet joints, your paraspinal muscles. Not the dramatic inflammation of an acute injury, just a constant slow burn, like a pilot light that never goes out. And here is the crucial part. Adequate magnesium directly suppresses substance P production. When you correct the deficiency, substance P levels fall. The inflammatory environment cools, the nerve amplification reduces, and the muscles, deprived of proper relaxation for so long, finally begin to release. Three mechanisms, all driven by one deficiency, all correctable. Now, here is the part that most people find hardest to believe, and I need you to pay close attention to this. Let me tell you what happened when I looked at Sandra's medical records. 4 years of treatment by multiple specialists, 2 rounds of physical therapy, 1 course of steroid injections. And in those 4 years, not one provider had ever tested her magnesium. Not the standard blood test. Not the more accurate test I am about to explain. Nothing. Her magnesium had never been measured a single time. Now, some of you are thinking, my doctor has checked my magnesium. And maybe they have, but here is the question. Which test did they order? The standard test for magnesium is called serum magnesium. It measures the magnesium floating in your blood, and your doctor looks at the reference range, sees normal or low, and acts accordingly. The problem is fundamental. Only about 1% of your body's total magnesium is actually in the blood. 1%. The other 99% lives inside your cells, inside your muscles, inside your bones and organs. And your body is extraordinarily protective of blood magnesium. When your muscle tissue starts running low, your body pulls magnesium out of those muscles and bones to maintain the blood concentration. It is a biological survival mechanism. But from a diagnostic standpoint, it is a disaster. Your blood test reads normal. Your doctor checks the box. Meanwhile, your back muscles are severely depleted, unable to fully relax, generating pain every single hour of every single day. The correct test is called a red blood cell magnesium test, sometimes labeled intracellular magnesium. It measures the magnesium inside red blood cells, which actually reflects what is available to your muscle and nerve tissue. It is a completely different measurement, and it tells a completely different story. This test is widely available, inexpensive, orderable through any standard laboratory, but it is almost never ordered when evaluating back pain, because the connection between magnesium and back pain is not part of standard orthopedic training, because there is no billing code that prompts this investigation, because the 7-minute appointment structure does not allow for this level of investigation. Johns Hopkins University researchers have published extensively on the gap between serum and cellular magnesium measurements. The serum test can read completely normal, while cellular stores are severely depleted. This is not a rare edge case. It is the norm in magnesium deficiency, and it is why millions of cases go unidentified. I ordered the red blood cell magnesium test for Sandra the same week she came to see me. Her result came back at 4.1 milligrams per deciliter. The optimal range is 5.5 to 6.5. She was severely depleted at the cellular level. Her standard serum magnesium, by contrast, showed 2.1, technically within the normal reference range, exactly why it had been missed for 4 years. Most people stop here. They hear the problem, they hear the test they need, and they assume this is rare. Let me be direct with you. It is not rare. Research consistently shows that between 65 and 80% of adults over 60 are magnesium insufficient when measured correctly. Think about that number. This is not an edge case. This is the default state of the aging body in modern life. And 3 specific factors explain why. Factor 1, declining dietary intake. The best food sources of magnesium are dark leafy greens, legumes, nuts, seeds, and whole grains. Multiple large dietary surveys show the majority of seniors fall significantly short of even the minimum recommended daily intake. Smaller appetites, changed food preferences, difficulty chewing certain textures. All of it compounds over years. Factor 2, impaired absorption. Stomach acid production declines naturally with age. And stomach acid is essential for proper magnesium absorption from food and supplements. But that is only part of the absorption problem. Consider the medications. Proton pump inhibitors, the acid reflux drugs, have been directly linked to significant magnesium depletion. The FDA issued a safety warning about this years ago. Studies show that long-term PPI users have meaningfully lower magnesium levels, and severe deficiency requiring hospitalization occurs at higher rates in this population. Diuretics, prescribed widely for blood pressure and heart conditions in seniors, drive significant magnesium loss through the urine. Diabetes and prediabetes, both extremely common after 60, are associated with increased urinary magnesium excretion tied to blood sugar elevation. Now think about how many people over 60 are simultaneously on a PPI, a diuretic, and managing prediabetes. Each medication creating a drain, each drain compounding the others, and nobody connecting these dots to the back pain that is ruining their quality of life. Factor 3, the testing failure I just described. Even when doctors want to check, they reach for the wrong tool. And the wrong tool says everything is fine when it is not. This is not a failure of individual physicians. This is a systemic failure. Doctors are doing exactly what they were trained to do in exactly the time the system allows. The problem is that the training did not include this, and the time does not allow for exploring it. The system failed Sandra for 4 years, but most people stop here. They hear the problem and they feel helpless. Do not stop here. Stay with me, because the solution is as specific as the problem. If this information is genuinely new to you, hit like right now. Not for me. Because when you do, the algorithm surfaces this video for someone else. Someone lying in bed tonight with the same pain, searching the same questions, and getting the same insufficient answers. Hit like and help me reach them. Most people reach this point in a video like this one, and they stop watching. They think they have the main idea. They will look into it later. Later becomes never. And 6 months from now, the pain is the same or worse. Do not be that person. The next section is where the real change happens, and it requires you to hear it completely. Now, let me walk you through the complete protocol, what to take, in what form, how much, when, and equally important, what not to do, because the form of magnesium matters enormously. And most people are taking the wrong one entirely. Here is something most pharmacies and supplement labels do not make clear. Not all forms of magnesium do the same thing. They are absorbed differently. They reach different tissues. And for back pain specifically, the form is as important as the dose. Magnesium oxide, the most widely sold form, found in most standard multivitamins, cheapest and most available. Bioavailability approximately 4%. 4%, that means for every 100 milligrams you swallow, roughly 4 milligrams actually reaches your bloodstream. The rest passes through the digestive tract unused. For correcting a deficiency, driving muscle spasm, and nerve sensitization, magnesium oxide is essentially ineffective. If this is what you are currently taking, this is almost certainly why you have seen no meaningful improvement. It is not your body's fault. It is the wrong form entirely. Magnesium glycinate. This is my first recommendation for back pain specifically. It is highly bioavailable. The glycine it is bound to has its own independent muscle relaxing properties, and it is the gentlest form on the digestive system, which matters for seniors who may already have gut sensitivity. The recommended starting dose is 300 milligrams of elemental magnesium as glycinate taken at bedtime, not the morning, not midday. Bedtime. Here is why that timing matters specifically. At night, your back is horizontal. The load of gravity is removed from your spinal muscles. Your body enters the period when tissue repair naturally accelerates. If you deliver magnesium precisely at this window, the muscles that have been chronically contracted all day finally have the conditions to release. The glycine component also supports deeper slow wave sleep, the phase of sleep where the most significant musculoskeletal repair occurs. You are not just supplementing, you are timing the delivery to align with when your body can actually use it. After 2 weeks, at 300 milligrams, if you are tolerating it well, you can increase to 400 milligrams. Do not jump to 400 on day 1. Give your gut time to adjust. Glycinate is gentle, but rapid dose increases in any mineral supplement can cause loose stools. Magnesium malate, the form I recommend if you want a second dose during the day. The malate component is energizing rather than sedating. It directly supports ATP production in muscle cells, which addresses the physical fatigue that accumulates in chronically tense back muscles. Take it in the morning or early afternoon, 150 to 200 milligrams, and now, the one that surprises most people, transdermal magnesium chloride. This is magnesium in oil or lotion form, applied directly to the skin over the lower back and hips. The magnesium absorbs transdermally, bypassing the gut absorption entirely. It does not matter what your stomach acid levels are. It does not matter which medications you take. The mineral goes directly through the skin and into the underlying muscle tissue. For seniors who are on PPIs or diuretics or who have any digestive sensitivity that makes oral supplementation inconsistent, transdermal magnesium is a genuine game changer. Apply it after a warm shower, when the skin is most receptive and pores are open, both morning and evening if possible. If only once, make it the evening. One caution many people do not expect. Transdermal magnesium may tingle or itch on first application, particularly on skin that is sensitive or dry. This is normal. It fades within a few minutes and usually reduces significantly after 1 to 2 weeks of consistent use. Diluting the oil with a small amount of water or applying a thin moisturizer first can help initially. Now, I need to be crystal clear about who should speak to their doctor before beginning any magnesium protocol. If you are on blood pressure medication, particularly calcium channel blockers, magnesium has complementary effects and your readings may change. Let your doctor know you are adding it. Your pressure should be monitored during the first weeks. If you have any history of kidney disease, any abnormal creatinine or GFR values from recent blood work, please consult your physician before beginning. The kidneys manage magnesium excretion. Impaired kidneys can allow magnesium to accumulate to dangerous levels. This is the one group where magnesium supplementation requires direct medical supervision before starting. And if you experience significant dizziness, unusual muscle weakness, or any symptoms that feel unusual after beginning, stop and call your doctor. For everyone else, this protocol is inexpensive, accessible, and the research supporting magnesium's role in muscle function and pain reduction is substantial. A 2022 meta-analysis published in the journal Nutrients, analyzing multiple randomized controlled trials, found significant associations between magnesium supplementation and reduced musculoskeletal pain outcomes in adults over 50. The effect sizes were meaningful in studies where the correct form was used at adequate doses. Let me tell you what happened with Sandra at 6 weeks. She sat across from me at her follow-up appointment, and for the first time since I had known her, she was not shifting in her seat. She was not adjusting her position every few minutes the way people in constant pain learn to do without realizing it. She told me her nighttime pain had reduced significantly. The muscle spasms that had been waking her between 2 and 4 in the morning, they were less frequent. Some weeks, they had not come at all. At 12 weeks, she described her overall daily pain as reduced by approximately 50%, not eliminated. Her discs are still degenerated. That structural reality has not changed and will not change. But the pain, the daily consuming pain that had defined her life for 4 years, was substantially less. At the 6-month follow-up, Sandra brought her daughter. Her daughter told me something I want you to hear. She said, "Doctor, my mother went back to her garden 6 weeks ago. Last Saturday, she was out there for over an hour. I watched from the kitchen window. She did not stop once." Sandra looked at me and said something quietly. She said, "I canceled the surgical consultation. I told them I did not think I needed it anymore." Then she paused and she said, "I just needed someone to ask the right question." 4 years. All someone had to do was ask the right question. Now let me be completely honest with you about what to expect, because honesty here is the only thing that actually helps you. Week 1. Most people feel nothing dramatic. This is not failure. This is your cells rebuilding depleted tissue stores. The muscles did not deplete overnight. They cannot replenish overnight. Stay with it. Week 2. Some people notice subtle changes, slightly reduced morning stiffness, a small improvement in sleep quality. Not dramatic, but real. The first small signs that the muscles are beginning to fully release at night. Week 3. This is the week most of my patients call me. Not because something is wrong, because something is clearly happening. The constant background ache, the one that is always there, regardless of position, begins to soften. Not disappear, soften. This is the moment most people who stuck with it start to believe the process is real. Weeks 4 through 6. Continued improvement, spasm frequency drops for most patients, energy levels in the morning begin to improve because the back muscles are no longer spending the entire night fighting their own inability to relax. The disc degeneration is still there, but the pain it was generating has lost much of its amplification. And here is what most people quit before they ever reach week 3. They tried for 9 days, they feel nothing dramatic, and they stop. Do not be that person. The discomfort of doing nothing has a name, and that name is surgery, or permanent pain medication, or a life increasingly measured by what you can no longer do. I know what some of you are thinking right now. This sounds too simple. If it were this easy, would not everyone be doing this? Let me be straightforward with you. The reason it is not already standard practice is not because the evidence is weak. It is because the system has no efficient mechanism for connecting a nutritional deficiency to a structural diagnosis. Your orthopedist looks at the disc, your cardiologist looks at the heart, your internist manages your prescriptions, and in the gaps between those appointments, the nutritional foundations of your pain go unexamined. That is not your fault. And it is not your doctor's fault individually either. It is a system's failure, and today you now know how to navigate around it. Here is your action plan. Write this down. 1. Ask your doctor specifically for a red blood cell magnesium test. Not the standard serum magnesium, the red blood cell version. If your doctor is unfamiliar with it, the lab code is erythrocyte magnesium, or RBC magnesium. It is available at every major laboratory too. If you are currently taking magnesium supplements and have seen no benefit, check the form immediately. If it says magnesium oxide, switch to magnesium glycinate, 300 milligrams at bedtime. 3. Add transdermal magnesium chloride oil applied to the lower back after your evening shower. This gets magnesium into the muscle tissue directly, regardless of what is happening in your gut. 4. Give the protocol a full 6 weeks before evaluating. Not 9 days, not 2 weeks, 6 weeks minimum. Your muscles need time to recover from what may have been years of depletion. 5. Tell your doctor what you are doing. Show them the test result when it comes back. A good physician will welcome that information. A great physician will want to understand it. Now, here is what I know with certainty. The majority of seniors with chronic back pain have never had their red blood cell magnesium measured, not because their doctors are negligent, but because the system built around 7-minute appointments and billing structures that reward procedures over investigation has no efficient mechanism for this. It falls through the cracks, not maliciously. Structurally, you now know what falls through the cracks. You now know the right question to ask. You now know the specific test, the specific form, the specific timing, and what to realistically expect. That is more than most people walking out of orthopedic offices today have been given. Do not let anyone tell you it is too late, because it is not. Type I finished in the comments if you stayed all the way through today. And share this video with one person in your life who is living with back pain and has been told management is the only option. You might be handing them the question that changes everything for them. And before I go next week, I am covering something that genuinely surprised me when I looked at the research. There is a habit that a very large proportion of seniors do every single morning that actively drives joint and back inflammation throughout the entire day. Most people never suspect it. That is next week. Stay subscribed. Do not miss it.